Hello everyone, this is Stephen-Castro, and I'm going to do a recording on the care of patients with dysrhythmias. It corresponds with chapter 34 in your book, and I'm going to try to keep this as brief as I can, and I'm going to do more traditional recording on this one because I can't really limit myself to the time constraints per slide on my other program. Okay, so the concepts that we are covering is perfusion. That's the primary concept, but it also overlaps with fluid and electrolyte imbalance, because we know that electrolyte imbalances can cause dysrhythmias, as well as clotting. We know that some dysrhythmias can actually cause clotting problems, or clotting can cause dysrhythmia problems in the case of an myocardial infarction. So we do have those overlapping interrelated concepts. So this is the picture of the cardiac conduction system. I do want you to be familiar with this. And know you had it in patho or even anatomy, but I do want you to just kind of review the conduction system of the heart. And it may have been a while, but we need to review it. This is the SA node. That is the normal pacemaker of the heart. Its intrinsic beating factor. It runs between 60 and 100. Remember, the normal heart rate's between 60 and 100. So this is the normal pacemaker. This is where all impulses should start. They don't always, but this is where it should start. And then from the SA node, it goes down through these little things here. This is called the internodal pathway. And that pathway will then take it to what's called the AV node. Kind of sits in the middle there on that right chamber. And then it'll travel down to the bundle of His. And then once it hits the bundle of His, it'll go branch off to the right and left bundle branches. And this is the right side of the heart, so it's the right bundle branch. And the left side of the heart is the left bundle branch. Because remember, we're looking at an anatomical position. So this would be the right and this would be the left. So it's going to travel down those bundle branches and then out towards the Purkinje fibers. And the Purkinje fibers will actually cause that muscle to contract. Okay. That is the normal pathway of the heart. And it does correspond with what you see on an EKG. That P wave, again, that is the SA node firing. When it travels down this PR segment right here, that's really kind of where it's coming from, the AV node to the bundle of His. That QRS complex, that's when you see the Purkinje fibers doing the contraction for the ventricles. And that T wave is when these are repolarizing, or kind of recharging, getting ready for the next contraction. Remember, discharge is called depolarization, and recharging is called repolarization. And there's just another picture. Again, normal, the SA node is going to be a 60 to 100 beats a minute. You'll see that as the P wave on that EKG. The AV node, that's that atrioventricular junction right in between the SA node and the ventricles. That's the PR segment, like I said, also known as the atrial kick. Kind of kicks that impulse on down through the ventricles. The bundle of His and goes out to the right and the left bundles and out to the Purkinje fibers. All right, so just a review of the electrophysiology of the cardiac cycle. There are some terms called automaticity, and that's the ability for a cell or a cardiac cell to actually charge or depolarize. Normally, that's going to be the SA node, but there are some occasions where some cells get irritated or excitable, and they will kind of take over with this automaticity. The excitability is how excitable they are if they do it a lot more frequently. The conductivity is how well it conducts, and the contractility is how well the muscle will respond to that electrical impulse and actually contract, cause those fibers to shorten and contract. The terms are located on page 665. Okay, this is a photo of the lead system, or the leads for a cardiac monitor. This is a photo of actually what we call a 12-lead EKG. And people say, well, why do they call it a 12-lead when there's only 10 leads? Well, it's because it gives like 12 different views of the heart. And I want you to think of each lead, because they're placed in a different spot, they're all kind of giving a picture of the electricity that's coming off the heart. So here you have your limb leads. There's one lead per limb or per extremity. Occasionally you can bring these limb leads up on the thighs or the limb leads up on the shoulders. Those you do have a little bit of mobility with. The ones you cannot move, they really are specifically to a specific intercostal space. That's going to be your chest leads. That's V1 through V6. And you don't have to memorize this for the exam. There's not going to be a test on where the leads specifically go, but just be aware that if you have a client that is getting an EKG at the hospital and you have a tech or some type of a person doing this skill, which they can if they're properly trained, just assure that they are actually doing the leads in the proper placement. Some of the concerns are people that have that are obese, or women that have extremely large breasts. Sometimes you have to move the breasts out of the way. I've seen people put the leads on people over the breast tissue, which should not happen. It needs to go under the breast tissue. So kind of just be aware of that. Now, when I talk about it's kind of giving a picture of the electricity coming off the heart, and this next picture kind of gives a better idea of it. So, for instance, lead 2, if you see the electricity, it's blue and it's coming out this way. If you look at lead 2, this shows the electricity or the impulses that are coming, what they look like coming off of this area of the heart. Whereas AVR is going to be up here kind of in that right anterior area up here. It's going to be way up there on the top. That's what it's given a picture of. So that's how they know when they look at a 12 lead EKG, and this is kind of corresponds with what a 12 lead EKG printout looks like. That's how they know where the damage is being done in a heart or where there are concerns at. So when you hear a doctor say, hey, they have an anterior MI, that's because in leads, these, not the septum leads, what it could be, but these anterior leads here, if you look on this EKG, these are the anterior leads that they're showing that there may be a problem. We know that it's going to be into the anterior of the heart. And then if it's lateral, so on and so forth, it corresponds to a specific area on the heart. So that's how it gives us a picture of what's going on and how we can look at an EKG and see precisely where there is ischemia or the infarct. And then we correspond that area, like where it is in the heart, and we can look at what vessels are typically there, like your right coronary artery, your left anterior descending, and the circumflex. Okay, the graph paper. Now, I want you to think of the graph paper as basically just kind of a way to measure time and height and distance. When I talk about big boxes, and I'm going to kind of refer to this thing here. When I talk about big boxes, that means one of these larger boxes with the darker, bolder black lines. That is a big box. When I talk about little boxes, that's this little bitty tiny box inside the big box. These big boxes represent 0.2 seconds of time. The little bitty boxes are 0.04 seconds in time. So if you do the math, if you take 5 little boxes, 4 times 0.04, you multiply that times 5, because there's 5 little boxes in one big box, that's going to be 0.2. So that's why one big box is 0.2 seconds. And you can take it one step further. How many boxes will it take to make 1 second? And it's going to take you 5 boxes, because 5 times 0.2 is 1. So 5 big boxes make 1 second. So we can continue that on further, and we try to measure out what's called a 6-second strip. And then you'll count the impulses for 6 seconds, and then you'll multiply that times 10, and that will be your heart rate. It's no different than when you feel for a pulse in feel for a brachial pulse or radial pulse for 15 seconds, and you multiply that times 4. We're doing the same thing here. We're just reading it for 6 seconds, and we're multiplying times 10. That's kind of how we can count the rate of our heart rate. So just kind of wanted to go over that. There are a few other methods. This one's called, I forget the name of it, but if the impulse goes from one box to another box, you know it's going to be 300 is how fast it'll be. If it's 2 boxes in length, it'll be 150. If it's 1 box in length, it'll be, or 3 boxes in length, it'll be 100, and so on and so forth. I can explain this a little better in class. It's a little bit easier to do when I'm actually in front of you. I don't like this method as consistently, because if you have an irregular heart rhythm, it won't be consistent. That's why this method is a little bit better. Okay. And we also use these boxes to measure our EKG complexes, such as the PR interval or the QRS complex. And we kind of measure how many little boxes does it take. So if it's 3 little boxes and each little box is 0.4 in length, or 0.4 seconds, we know if we 3 little boxes times 0.04 is 0.12. It's all just basic multiplication. And we will practice this in class. I don't want you to get overwhelmed because I know talking about it on a PowerPoint slide really doesn't transcend really well. But we will go over this in class, and we will do some practice on Tuesday. All right, so this kind of shows the waveforms. Again, I was talking about a 6-second strip. This is exactly what I'm talking about. If you counted out all these big boxes, 1, 2, 3, 4, 5, that's 1 second. 1, 2, 3, 4, 5. This is 2 seconds. 1, 2, 3, 4, 5. That's 3 seconds. And then you repeat the process. This is a 6-second strip. So I can tell how fast this heart rate is just by counting the impulses within this section, within these 6 seconds. So I would say this is like a half because it's not quite a full impulse. But I could say 1, 2, 3, 4, 5, 6, 7, 8, 9. So since this one was a half, I would estimate that this rate is somewhere around 85. That's how we count those. And we will practice that come Tuesday. All right. Again, our segments and complexes, that P wave, the PR segment, the PR interval, QRS complex, QRS duration, ST segment, T wave, U wave, and QT interval. I don't want you guys to get really worked up on QT interval or even the U wave at this point. Really what you need to focus on for the exam is the P wave, your PR interval, your QRS complex, the ST, and the T wave. Those are really the priority at this point. Everything else will come later. So this is what a normal EKG looks at. When we talk about measuring, this is what you're going to be measuring. First of all, we're going to look at the P wave, and ideally it's upright and front, and it always precedes a QRS complex, ideally. It should be nice and upright, and there's our P wave. And then we will measure what's called the PR interval. So that's going to be from the very beginning of the P wave where it leaves the baseline, and they're going to measure all the way over to before it leaves the baseline for the QRS complex. We will be measuring the PR interval. Remember, that's how long that interpulse takes from the AV node to the bundle of His, okay? And then the QRS complex, remember, this is our ventricles firing, so we need to see, and this is how long it takes the electricity to travel through that pathway. We're going to start where it leaves baseline, and then when we're going to finish when it returns to baseline. So this is called the QRS. And depending on what lead you look at, this complex may be flipped upside down, the QRS, just depending on where you're looking at. Remember, it's always kind of looking at that view. If it's looking at it from up top, it may be inverted. If it's looking at it from the bottom, it may be right side up. So it just kind of depends on what lead you're looking at. And then don't worry about the J point at this point, but we do want to look at this ST segment, because the ST, we have S and T, we always want this to come back down to baseline. When we talk about acute MIs or myocardial infarction, this is where you're going to see ischemia and infarct. The ischemia, frequently we're going to see this T wave. It will be inverted or upside down. If you actually see necrosis or cell death, this S wave never comes back down quite to baseline, and it kind of has a big, and I had another picture on my other slideshow, but it kind of has like what we call, looks like a tombstone T wave. It just kind of falls all the way over here and never comes back down to baseline. We always check that to make sure it's coming back down to baseline, to make sure our clients or patients, especially if they're having chest pain, that they're not having some type of a cell death or cell necrosis, or something that might indicate that they're having a myocardial infarction. So our analysis, what we need to do, we're going to determine the rate, and I talked about that briefly. We're going to determine the rhythm, and basically that's just, is it regular or is it not regular. Most people, healthy, normal heart rate should be fairly regular. They're going to speed up and slow down with some activity and some deep breaths, but for the most part, they should be fairly regular. We're going to look at those P waves, make sure they are appearing normal. We're going to measure that PR interval to make sure it's not lengthened, to make sure there's not a delay. We'll measure the QRS, and that's the impulse going through the ventricles, and then we'll try to do a basic interpretation. It's just basic interpretation. And we will practice this on Tuesday. It'll make a lot more sense when you have someone there kind of going over it with you step by step. So you can thank Sean Herco for this. I am so excited that he created these little files, these little animated files to show you exactly kind of what I want to talk about. This is what's called normal sinus rhythm. It's the absolute most normal rhythm that we should all have if we're nice and healthy and have no issues. If you look here, we have our P wave and our measurements are within normal limits. And again, I'll go over those measurements on Tuesday. Our PR interval is normal. Our QRS is nice and narrow because its impulse is going through those ventricles really quickly. And then you have a nice T wave that's not too peaked. And it comes back down to baseline, that's showing that the ventricles are repolarizing. So you have the P, QRST. You can see the heart beating normally here, just like it normally would, between a rate of 60 to 100. And I counted this, and Sean has this little guy going just about 80 beats a minute, maybe 80 to 85-ish. So this is an absolutely normal heart rate, and it corresponds. This is what it's going to look like on your rhythm strip. Again, the rate's going to be 60 to 100. The rhythm should be regular, should be fairly consistent, fairly spaced out, pretty regular. The P waves are present. They're going to be upright, and there should be one P wave in front of every QRS. And if we measure that PR interval, and again, we'll practice that on Tuesday, we should measure it from 0.12 to 0.20, and that's going to be 3 or 4, or 3 to 5 of those little boxes. And if we measure the QRS, that's going to be 0.04 to 0.10. And again, those are going to be those little boxes. We're going to measure those little boxes, and that tells us how long or how many seconds they are. So here's another couple of pictures of sinus rhythm. This one's obviously a little faster. Then this one is a little bit slower. And if you look up here, here's our 3-second tick marks. So I could count the rhythm in this rhythm right here again. Again, this would probably be like a half of a rhythm because it's right in the middle of the beat. So I guess 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12. 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12. This one's a little fast. Let's see. But it is still a sinus rhythm. You can see you've got your P wave. It's upright. If you measured it, it would probably still have the correct measurements of the 0.20 or less. The QRS is nice and narrow. I can see it's just about 2 boxes wide. But this is just because it's faster. This would be called sinus tachycardia. And so, again, I measured like 120 on that. Now, this one, on the other hand, here's our little tick mark. So we can measure that one too. 1, 2, 3, 4, 5. So this one's actually a little slow, but it's still sinus. Again, you got a P wave before every QRS, and then you have a T wave. Those QRS complexes are kind of hard to see on this picture, but it's the one that was provided by the book, and they correspond with what's in your book. So just kind of show you that these are sinus rhythms, even though this is tachycardic, and this possibly could be a little bradycardia, but they're all sinus. Remember, normal sinus rhythm is between the rate of 60 and 100. All right, sinus arrhythmia, on the other hand, it's still a sinus rhythm, but it's got a little irregularity to it. And if you look here, you've got this little P wave here. You've got your QRS and your T, P, QRS, and T. And these two look fairly spaced out pretty evenly, but this one and this one over here and this one here are not quite spaced out evenly. And when we get into the classroom, I'll show you how we'll measure these to measure for regularity. But this can happen for one. There could be a few reasons for having something like a sinus arrhythmia. They may just have some underlying problem with the SA node, or this also happens frequently when you're taking a deep breath. When you take a deep breath or hold your breath, sometimes it slows down the heart rate a little bit. This can also happen with that as well. And then we're going to go over some other common dysrhythmias. The rhythms I have up here are called bigeminy and trigeminy, and we will talk more about that later on in this PowerPoint. Don't get too focused on it yet. But we're going to go over the most common dysrhythmias that you'll need to know for the exam and for the NCLEX. All right, first two most common, sinus tachycardia, which is just a sinus rhythm that's a little fast, and sinus bradycardia. Still a sinus rhythm, which means the beat is originating in the SA node, but it's a little slow. And let's talk about your nursing implications. What are going to be your responsibilities for these patients? So, this is sinus tachycardia. And look, he's just beating pretty fast. See how fast he's going? Sinus tachycardia typically runs somewhere between 100 to 160, and rarely does it go faster than 180 beats per minute. If it's faster than 180 beats per minute or even 160 beats per minute, generally there's some other underlying cause. It's not a true sinus tachycardia. So sinus tachycardia just basically tells us the beat is still originating from the SA node. It's just the heart rate is really fast for some reason. And typically this rhythm is because there's an underlying cause: dehydration, fever, activity, exercise. And so if they're having a problem with sinus tachycardia, we have to look at the underlying cause and treat that. If it's due to a fever, we're going to treat the fever. If it's due to a lot of activity, we'll have them rest. If it's due to dehydration, we're going to give them some fluids. If it's due to caffeine, we'll need to cut them off of the caffeine. So kind of look at that sinus tachycardia. You're just going to treat the underlying cause of what's causing the tachycardia. It's a normal sinus rhythm, still have your P and your QRS, everything falls within the normal limits. It's just faster than 100 beats per minute, but no faster than somewhere between 160 and 180. That's about where it tops out. Okay. And this is called sinus bradycardia. It's same principles, still a sinus rhythm, beat is still originating from that SA node, it's still following down the internodal pathway to the AV node, down through the bundle of His and making those ventricles contract, but it's just slower than 60. The thing with sinus bradycardia, you should always evaluate your client and make sure that if they are symptomatic or not. Sometimes if there are people that are very well conditioned, like marathon runners or people that do a lot of cardio activity, they may have very efficient heart rates, and sometimes they tend to run a little bit slower. My son, for instance, runs marathons, and his heart rate intrinsically only is somewhere in the low 50s. And that's just because he just does a lot of exercise and he's very thin and fit. Now, pathologically, sinus bradycardia, that might be another issue, or there may be some type of a problem with the SA node. And we typically don't really do much with our sinus bradycardia unless it's really severe or it's causing perfusion issues. If it's beating so slow that they're not perfusing and we're having symptoms or other clinical manifestations, that's when we're really going to need to treat this sinus bradycardia. So, what kind of clinical manifestations do you think you're going to see with symptomatic sinus bradycardia? Well, if the heartbeat is not pumping fast enough and it's not perfusing well enough, you know you're going to have pallor. They're going to be dizzy. They may have hypotension. They may be diaphoretic. They may be unconscious. Think of those types of symptoms that would correspond with the body's just not getting enough blood pumped to its organs, tissues, heart, lung, brains, all those things. And those are the manifestations you're going to look at. If somebody presents like that, then you're absolutely are going to have to take action to treat the sinus bradycardia. And so we have to see if there is any type of underlying cause that may be causing this sinus bradycardia. But the medication of choice that they typically prescribe for sinus bradycardia is going to be atropine, and that's going to be 0.5 milligrams IV. And I know that they've talked about this in pharmacology class. And it helps kind of increase that volume and helps kind of keeps the heart running a little bit faster. It's an anticholinergic. If it's due to other medications, perhaps like digoxin or a beta blocker. Remember, you should be checking your heart rate every time you give a beta blocker. then we're not going to get that, or we're going to hold that medication. If addressing one of those two measures, either the atropine or treating the underlying issue that may be causing the bradycardia, if it doesn't work and our clients are really kind of deteriorating and they're not doing well, they may go directly to what's called transcutaneous pacing. And basically kind of what that is, and it would be done in a hospital with one of the life packs or one of the defibrillators. They would hook them up to the paddles or to the patches, no different than what they look like on an AED. And it would give a smaller joule of a charge, but it will give a transcutaneous pacing. It will start giving little shocks every so often to make sure that that heart stays, continues to beat at a regular rate. And there's a lot more detail involved with it if you do that, but you don't need to know more than that, other than the basics. When you start working, you'll take ACLS and you'll learn a lot more about how to get capture and all these other things. But that's kind of just to understand that transcutaneous pacing is probably the next step. And then once they get stabilized, they may need an actual pacemaker, an implanted pacemaker, if there is some type of problem intrinsically wrong with the SA node. Okay, here we go to pacemakers. Again, temporary pacing, that's that invasive and non-invasive. Transcutaneous is kind of the emergency pacemaker that they can do. They can also do like an emergency pacemaker for just like a short period of time where it's actually implantable. Permanent pacemakers, again, are those pacemakers that are implanted under the skin. I assume you guys are probably somewhat familiar with the pacemaker. You may even had a patient with one. It looks like a little battery pack just underneath the skin in the chest area. It's a little pulse generator. There's different settings on them. Some people have some that will only kick in if the heart rate drops below a certain rate. Other people have it constantly pacing no matter what. And that's going to be all determined by the cardiologist, but that's just kind of some general information on your pacemaker. Now, when you have a client in the hospital that has a pacemaker, their rhythm really does look different. For instance, this is a paced rhythm, and if you look up here, you can see that little P wave, but for whatever reason, I don't know the history of this patient, but it doesn't look like that rhythm was making it from the P wave all the way down to the QRS complex, so they implanted a pacemaker to help stimulate the ventricles, and that's why you see this spike. This is a pacer spike, and it's right preceding that. This is a wide QRS, and that's because it's a paced spike. But you have the P wave, a pacer spike, and then you see the ventricles contracting, and this is the T wave. This is a pacer spike. And conversely, if you look at the one at the bottom, this is called a dual paced. So this would be pacing for the SA node because there is no P wave, and then this is the pace for the ventricles, and then you can see that wide complex, and then the T wave. So this is a dually paced patient. This is a singly paced patient. I just wanted you to be able to recognize pacer spikes if you saw them. Again, they won't be on the exam, but they are seen so frequently just so you can kind of recognize what they may look like. All right, premature atrial complexes, again, will not be on the exam, but I am going to kind of just cover it so you know what they are. And we talked about that excitability when we talked about earlier in the presentation. Sometimes that SA node gets a little excitable and it wants to kind of contract a little early. And that's what's going on here. You have your SA node beating normally. Here it says reset, so this is where it normally is. And then for some reason, you can see the T wave just starting to repolarize, not even halfway through its repolarization before that SA node takes off again. So it's coming off too soon. And then it kind of like stops a little bit. You got a normal beat here, and then again it goes off a little bit too soon. This is called a premature atrial complex. Sometimes the SA node gets a little excitable for whatever reason and wants to do its little discharge a little premature than it should be in a normal sinus rhythm. All right, so we're moving on to supraventricular tachycardia, and I know that's a mouthful. Okay, my computer froze. I'm a little technical difficulty. So this is called supraventricular tachycardia. Big word, supra, which means above the ventricles, or above ventricular ventricles tachycardia. So basically all this is saying that this is a really fast tachycardia that is generating somewhere above the ventricles. But they can't say it's going to be the SA node because it could be anywhere up there above the ventricles. Remember that term, excitability? Sometimes you get lots of impulses or lots of issues going on, and it may be the SA node, but it's typically a little bit faster than normal tachycardia or sinus tachycardia. This is typically about 170 beats a minute and maybe a little faster. The term paroxysmal supraventricular tachycardia, it's a rhythm that people go in and out of, and usually that they know, they have a history of it, and they'll go in and out of it on occasion. If it starts to have problems or complications, they may end up needing a procedure called an ablation or some type of procedure to help control that rate. All right, and you can see our little guy's just really beating pretty fast. That's called supraventricular tachycardia. It's a really fast tachycardia that is just where the beat is generating somewhere above the ventricles. And if you look really closely, I do want to point out, look how narrow these complexes are. You can't see the P wave, and that's part of the reason you can't see it is because it's buried. It gets lost within these QRS complexes because they have so much more energy. Basically, all we see here is a QRS and a T wave because it's so fast. I do want to go over your nursing responsibilities with supraventricular tachycardia before I move on to the next rhythm. We have to always look if our client is stable or not stable. And when I talk about stable, do they just feel palpitations? Is their blood pressure being maintained? Or do they look pale, diaphoretic, hypotension? So kind of look at your client and look, are they stable or are they unstable? If they are stable, you can do more conservative measures. We want to do as conservative measures as possible as long as our clients are stable. The minute they become unstable, we have to act more quickly and more urgently. So kind of think about that. Treatment for supraventricular tachycardia. If they are stable, we can try what's called a carotid massage. Nurses do not do this. This is something that typically a physician will come in and do. It stimulates the receptors in the carotids, which can cause bradycardia. We can also have them try to perform some vagal maneuvers, such as bearing down, to see if that will slow down the rate. But sometimes it does frequently help slow it down briefly, but I haven't ever really seen it work very often to where it will help sustain or take them out of this rhythm. If they require other interventions such as medications, the medication for supraventricular tachycardia is going to be adenosine, or Adenocard is the trade name, and it's usually given in a 6 milligram dose, and if that doesn't work, then they're going to move up to a 12 milligram dose. And if that doesn't work, to try to reset that pacemaker, they may need what's called a synchronized defibrillation. And it is a shock to the heart, but it's synchronized with the rhythm, so it's only given at a specific time. And it has to be done on one of the cardiac monitors to give that specific shock. It's usually a lower joule than you would give for a cardiac arrest. And it's done again at a specific cycle. The machine, the computer in the EKG machine or in the monitor can tell exactly when to deliver that shock at the exact right point to try to reset that pacemaker of the heart. So that is ventricular or supraventricular tachycardia. Our next rhythm is atrial fibrillation, and we've talked about atrial fibrillation a lot already. Atrial fibrillation is exactly kind of how it sounds. It's that atrium, typically where the SA node is, and it's fibrillating. It's not doing an actual contraction. It just kind of fibrillates, kind of like just like a fish out of water is kind of what I kind of akin it to. And so there's no real contraction done in that atrium up there, in that right atrium. When you know the blood's kind of dumping in that right atrium. So if the blood's not being contracted out, there's a high likelihood that it can pool and clot. And these clots can turn into little microthrombi when they do actually get contract and go through the heart. And this is what can lead to strokes and all those other potential issues from atrial fibrillation. You can't see a clear P wave because there is no contraction. A lot of times it's like the impulses don't always get through at the same time, so the rhythm is consistently irregular. What they like to call it is regularly irregular because it is almost always irregular. There is some etiology, which I did talk about that with a stroke, that can lead to atrial fibrillation. It is probably the most common dysrhythmia. It is the most common dysrhythmia, and it is more common with age. I will be hard-pressed if you do not make it through nursing school without at least caring for a few clients that have atrial fibrillation. Medications that we give atrial fibrillation, what we like to do is control the rate. We need to try to keep that rate, again, somewhere between 60 and 100 for those QRS complexes. The problem occurs when a lot of those fibrillation impulses make it through all the way to the QRS or to the ventricles, and you get what's called rapid ventricular response. So instead of having a rate of 80 to 90 or even 60 or 70, you get the ventricles are trying to catch up with all that fibrillation, and you'll see rates higher than 150, 160, and somewhere around there. We can start about 120. You actually can start a little bit lower than that. But that is where it really gets really concerning, is when you start to have that rapid ventricular response. Always kind of akin it to the ventricles are trying to catch up, or a lot of those impulses are getting through, and so it's trying to contract and keep up with the impulses that it has that are being generated. Medications to help control this. Again, we want medications to kind of help control the rate. One of the cardinal medications is going to be a calcium channel blocker, which is cardizem. Occasionally they may give a digoxin. And it looks like I had another issue. Hold on. There we are back. I've just been having some issues with my computer in the last couple days, so I apologize. Again, we just want to control that rate. There are a lot of other medications that can help control the rate, some beta blockers and some other things, but typically the most common weapon of choice is going to be a calcium channel blocker, and they like to use cardizem. Frequently, these clients also need to be anticoagulated, either with an aspirin or some type of medication to try to prevent them from having that clot formation, which can lead to stroke. High risk for stroke. Ischemic stroke. So this is atrial flutter, and you kind of get they're fluttering the right atrium, particularly where that SA node is. But this one is almost characteristic. It looks like sawtooth, very similar to a flutter, but it's more atrial fibrillation. But instead of just fibrillating, there's a more organized flutter to it. It's still not contracting fully, so you still have the potential risk for clot formation. It just looks a little bit different. You're always going to see this characteristic sawtooth pattern for atrial flutter, and it really does look like a little sawtooth pattern. Same concerns with atrial fibrillation you would have with atrial flutter. You will probably not see atrial flutter on your exam, and I would be surprised if you saw it in the NCLEX exam, but if you've seen AFib and know how to treat AFib, you would know how to kind of treat a flutter as well. They're just a little bit different on presentation. All right, interprofessional collaborative care. Again, what we're going to notice, we're going to look, is there a problem with perfusion? Is this rhythm, or whatever rhythm they're in, causing signs of perfusion? So what are your signs and symptoms of poor perfusion? Color, their pallor, if they're hypotensive, capillary refill. What signs and symptoms would you see, or clinical manifestations would you see of poor perfusion? Anxiety. Anytime you have cardiac issues, a lot of times they have an impending sense of doom or a lot of anxiousness, which is understandable because they can lead to some serious complications. We'll have to get that 12-lead EKG to see what the underlying rhythm is and do our basic interpretation. And then take action depending on what the rhythm is. Again, there's going to be potential for embolus formation, especially with atrial fibrillation, and potential for heart failure, especially with clients that are having issues with Left ventricular failure could be related to MI or ischemia or infarct. Planning and implementation, responding, again, just try to prevent that embolus formation. Put them on anti-thrombotics or blood thinners, and preventing heart failure. There may be medications involved with that. Sometimes they like to use positive inotropes to help strengthen those heart contractions. Just have to monitor those really, really closely because that also does increase oxygen demands. Non-surgical interventions, I did talk about some of these. This is called electrical cardioversion. It is just no different than a defibrillation. It's just a smaller amount of electricity, and they're usually delivered at a specific time in the EKG complex, or in that EKG complex at a specific time. Left atrial appendage closure, radio frequency catheter ablation. I did talk a little bit about ablation. Sometimes they kind of zap the SA node. If they have some of those clients that have supraventricular tachycardia or problems with that, they may kind of zap it with those radio frequencies to try to keep it from going into those rhythms. The biventricular pacing I talked about already. Other surgical interventions might be the MACE procedure, but I think we talked about everything that you need to know. Self-management and education. Again, medication therapy, I discussed those anti-dysrhythmics and anticoagulants, and lots of education with your clients, especially with pharmacology. Ideally, we'd like them to remain embolus-free, especially if they have atrial fibrillation, since that's the most common rhythm. You can almost guarantee that you're going to see a question or two on the exam about atrial fibrillation. It relates to strokes, it relates to other complications, and it's the most common dysrhythmia. So just by process of elimination, you know that's going to be one of those rhythms that you're definitely going to need to know for the exam. And your nursing implications. So now we're moving on. We've kind of worked at the top half of the heart. Now we're going on to what's called the ventricular dysrhythmias. So the ones that kind of occur more at the bottom half of the heart. We're going to talk about premature ventricular complexes, also called PVCs, ventricular tachycardia, ventricular fibrillation, ventricular asystole, or just asystole. Again, these are more life-threatening than atrial dysrhythmias because the ventricles are really what I call the powerhouse of the heart. They're the ones that do the pumping to get the oxygenated blood throughout the whole body to help perfuse all of our organs and vital tissues. So let's talk about some ventricular dysrhythmias. All right, so we're going to start off with something called a premature ventricular complex, or a PVC. Basically, it is, for whatever reason, and usually there's some type of underlying cause, the ventricles will kind of get a little irritable or a little excitable. We can talk about excitability, or I call it also irritability, and for whatever reason, they want to depolarize all their own without getting a impulse from the SA node. They just fire on their own. That's kind of what's going on. They get irritable and they fire on their own. So if you look at this top rhythm, you have, it looks almost like a nice PQRST, you're going right along, and then you get this big wide complex. So this is the ventricles when they have an impulse all by themselves. When they do that premature ventricular complex, they charge off all by themselves. It's usually a wide complex, and there's no preceding P wave. Remember, this is the T wave from this previous complex. If you look at these two, they look identical. So we call that unifocal PVC because they're coming from the same spot in the ventricles. Whatever irritated spots in the ventricles, it's causing this ventricles to have that conductivity. It's coming from the same exact area. Now, the one on the bottom, on the other hand, if you look at this one, again, you have a PQRST, you have this big wide complex, this is a PVC, and you go back into this normal sinus rhythm, and then you have another big wide complex, but they do not look like each other. They're called multifocal, so you have a couple of irritated spots in the ventricles. The multifocal are a little bit more concerning than a unifocal because it's easier to manage one irritable spot versus multiple irritable spots. The other concern is when they start to happen in more frequency, because a premature ventricular contraction, if you get several of those in succession, that can turn into ventricular tachycardia, and that may lead to a lethal rhythm. So they could lose their pulse with that. So that's why we always monitor and make sure that they're not having more than around 10 a minute. All right, ventricular tachycardia, also known as V-TACH, pretty regular, big, wide complex. You don't see any P's, no narrow QRS. It is just a big, wide complex. This is called ventricular tachycardia. The ventricles are taking over and they're just beating all on their own. It usually runs between 140 and 100 beats per minute. You may or may not have a pulse with this. If they do have a pulse, they could lose their pulse because this can go into a cardiac arrest situation fairly quickly. So we need to monitor them very closely and make sure it's not sustained, or do what we need to do to kind of get them out of this rhythm by even giving them anti-arrhythmics if possible. Again, irritable ventricle ectopic foci. So there's an irritable area in the ventricles that's kind of taken over as the pacemaker of the heart, and it's a tachycardia, so it's going fast between 140 and 180 beats per minute. This is the most common rhythm that precedes cardiac arrest. So just kind of, this is usually like the initial rhythm that they go into before they go into ventricular tachycardias and ventricular fibrillation are the most common rhythms that they precede before they go into cardiac arrest. Medications to treat this. If they are somewhat stable and with a pulse, you're just going to follow the ABCs. Airway, put some oxygen on them, breathing, help assist their breathing if needed, and circulation. And then they may need medication such as an anti-arrhythmic, such as amiodarone or lidocaine. There are some lists of some in your book, and I know that they already went over those with you in pharmacology. If these clients become unstable or they lose their pulse with this rhythm, this turns into a cardiac arrest situation, and they're going to need immediate defibrillation. All right, so there it is again, and I kind of hid the the atria on the cart because I really wanted you to focus on the ventricles because they're really kind of like taking over. They're really kind of like taking over, and everything else is secondary. A ventricular tachycardia or V-TACH, and it typically runs between 140 and 180 beats per minute. Very consistent, wide complexes. That's all you see, just wide complexes. This is also considered a ventricular tachycardia. It will not be on your test, but I would not be surprised if you didn't see it somewhere in the NCLEX exam or somewhere. This is called polymorphic V-TACH, or the other term for it is called torsades de points, and it's French for twisted points. And if you kind of look at the rhythm, it almost looks like if you had a ribbon and you twisted it. It gets wider and then goes back to narrow, and then gets wider and then goes back to narrow. It is a ventricular tachycardia, and basically, remember we talked about the ectopic foci, or the irritable spots in the ventricles that kind of take over. Instead of just having one spot, this one has multiple spots, and it's like traveling around a little bit, which is why you see it going from narrow to wide, and back and forth. It's called torsades de points, or the technical term for it's called polymorphic, which is many morphic. It's coming from many spots. Ventricular tachycardia. Treatment of choice for this particular rhythm is going to be magnesium, of all things. So this can be related to magnesium. Also, if they lose their pulse, they may get shocked as well. Just kind of throwing that out there as well. They may or may not have a pulse with that as well. But again, I won't have that on your exam. It's just kind of FYI information for future knowledge. All right, ventricular fibrillation, and it's just like AFib. It's not a real contraction. They're just fibrillating out there. There's no real contraction, so there is no blood pumping, so they will not have a pulse with it. If you look at this, it is just kind of all over the place. They're not consistent. They're all over the place, and it's just fibrillation. Also called VFib, just lots of chaos in the ventricles. This client is going to need CPR and immediate shock, if they can get a shock as soon as possible. This rhythm, kind of consider it like a battery that's going dead. The longer you have this, eventually the impulse will wane down. And once you lose that electrical activity in the heart, it's almost impossible to get back. So this is why these clients need shocked as soon as possible. Again, one of the most common rhythms that they will go into for cardiac arrest is called ventricular fibrillation, and it's right here. And there is another picture of ventricular fibrillation, VFib, electrical chaos, but no pumping. There is no contractions, no pumping. All right, and ventricular asystole, you can see it's just kind of like sitting there. There might be a little quiver, but there is no actual beats, no movement, no anything's going on in this rhythm. It's a flat line. Occasionally you might see a little blip or something like that, but for the most part there is no perfusing rhythm and no real electrical activity coming off of the heart. This is asystole. It's called ventricular standstill, asystole. If you have a client with this, they're just going to need CPR, cardiopulmonary resuscitation, good CPR, and review your CPR basics, although I should not going to be testing you over that all over again. But remember, at least 100 to 120 a minute, 2 inches on the chest, 1 breath every 6 seconds, and you're going to switch out rescuers every 2 minutes because you want to make sure that your contractions are being, or your compressions are efficient and they're meeting the guidelines for what they need to maintain perfusion. Yeah, these just need CPR, and there are some other medications that they give for what's called ACLS, or advanced cardiac life support, but again, I'm not quizzing you on that. They might quiz you on that in pharmacology. You will learn more of that when you actually take an ACLS course when you start your job. We typically give epinephrine, which is, kind of like it's epinephrine, kind of gets the jump start of the heart. They'll get epinephrine and CPR to see if we can get some type of discernible rhythm back for these clients. If a client actually does go into asystole, the chances of getting some type of rhythm back is pretty slim. You have a much better chance if they're still in V-TACH or VFib in those shockable rhythms. But once they get into asystole, it's almost impossible to get any type of cardiac rhythm back. Here's another picture of ventricular asystole. You can see it's pretty flat line. There's one little blip, but there's nothing going on here. All right, again, CPR, ABCs, make sure airway's patent, use that mass device. If for some reason you don't have one available, you can do hands-only CPR. Start those chest compressions as fast as possible. Make sure you start the emergency response system. In the hospitals, a lot of hospitals are now requiring advanced cardiac life support. I was a ACLS instructor for many years. I just let my instructor card go in the last year. So if you have any questions about that, please don't hesitate to reach out to me. Again, defibrillation, I talked a bit about it, that asynchronous countershock, that's what those ventricular rhythms are going to take. If they have a pulse, it will be synchronized. If they have no pulse, it will be asynchronized. It's just going to shock them. The asynchronous shocks are going to help depolarize that critical mass of the heart to try to get things to kind of restart. The AED, you should be familiar with an AED. That's that automatic external defibrillation machine that's frequently in malls and grocery stores and everywhere around. Everybody who has had CPR or BLS for this course or for nursing school has already checked off on the use of an AED. Number one rule is turn it on and follow the prompts. I do want you to kind of reiterate what are your steps before you deliver a shock. Make sure you always clear the patient before you press that shock button. That is a critical step. You do not want to be shocking anybody else that is not supposed to get a shock. And there's a couple case studies. I'm not going to go through them on the PowerPoint. The answers are in the notes on the PowerPoint, so if you want to look at those. If you have any questions for me, don't hesitate to reach out. Sorry it was so long, but I wanted to make sure to go over it with you in detail. We will discuss a little bit in class and do some exercises.